Welcome everybody to Pride at Home, Platinum Rainbow Guidance for Home Care. This is the team and some online, and we would like to introduce ourselves. I'm Dr. Mel Duffy, and I have the privilege of being the PI on this research project. Beside me, to my left, is...
I'm Anthony Staines. I work with Mel in PCU, and I work on the survey element project.
My name is Claire Mooney, and I am a retired nurse with 20 years in gerontology and older person's care, and at the moment I'm working as a psychotherapist, and I'm one of the PPIs on the project.
Hello, I'm James O'Hagan, and I work with LGBT Ireland. I feel like I did virtually nothing with this amazing team that were doing all of the work, and I was just sort of coming in at the end to say that looks nice. The work I do in LGBT Ireland relates to the care needs of older members of the LGBTI plus community, so this was a great project to be involved in.
And my name is Sean Bale. I am an advocate for LGBTQIA plus and for autism. I'm in the category of being an older LGBT person, so like first-hand experience.
My name is Alejandro, and I'm studying at college in security, and I like to stay here.
Thank you.
And I'm James Gahagan. I'm a nurse by background, and I'm the operational lead for a community specialist team with older persons in Galway East City and County, and was a member of the PPI group on this excellent piece of research.
I'm Alva Smith, and I'm a campaigner and an activist on feminist and LGBTIQ plus and other social issues, and I was the founding head of women's studies at UCD, and I am extremely pleased to be here with you all today.
So we originally named this Home Care Inclusive and Diverse. So we called it HID. And what we wanted to do was explore by a hermeneutic phenomenological approach, which really is the lived experiences, the meanings and understandings that people bring to something. So what we were looking at was the meanings and the understandings that community dwelling older people in the LGBTI community, 50 plus years, and their experience of receiving home care in Ireland. So that was phase one of our study. Phase two was looking at the survey of care workers. And what we wanted to look at was their attitude towards people who were LGBTI and what their level of knowledge was. And those between phase one and phase two, we developed an LGBTI inclusive educational resource for health and social care providers, volunteers, or anyone interested in this whole area of caring for older people. And that is available on the Future Learn platform, and we'll talk about that after a while. We had 14 people who participated in our study, and we had a wide range of people. So we had lesbian women, gay men, we had bisexual man, we had a transgender woman, and the only group we didn't have was a member of the intersex community. But I hope if we do this kind of study again, we will be able to have them as part of it. 9 were living in urban areas, and 3 reported that they were living in rural areas. All the participants chose to be interviewed through Zoom. So we didn't, which meant really that we were sitting in our offices or at home, and we were interviewing people on Zoom in their own time, in their own place, and at their own space. So moving on, we then wanted to look at really was levels of mutual knowledge. So what do the caregivers understand about the recipients? And what we looked at with that were 3 elements. Aging in place is really about living at home. And your home is your castle, it's your own space, and it is here that we are safest. In the main, we know from domestic violence, that doesn't always carry through. But we would take it from the rose-tinted way of viewing it today, that it is our safe space. We talk about taking risks. When do we disclose? Do we tell people who we are? And you know, it's one of the, if you belong to the community, you well know it is something that is continuous over our lifespan. And if you come from the heterosexual community, you understand that this is something you never have to do. You never have to tell somebody you're heterosexual or straight. But continuously, members of the community do have to. And then finally, how do we come to terms with having a stranger come to our house and deliver home care?
And over to me. So I think one of the core pieces of what this research is looking to understand, or has been looking to understand, is what it means to have your safe haven, or the place where you feel fully able to be yourself. Have a new person come into that, and the juxtaposition of that person viewing your home as a place of work while you're doing it as a home. And through, I suppose, my work within LGBT Ireland and the experiences of many of the older LGBTI plus community who would have shared their experience with us, we know that many people that are older people in our community oftentimes don't feel empowered to be openly themselves or fully themselves outside of their home. So this becomes the safety of your home is really incredibly important. And you see through the interviews that were undertaken, some of the thoughts and feelings that our participants had, thinking about how it was strange, most times difficult to confide in the people who come to give you this care, and the concerns about how they are going to treat them once they discover that this is part of who they are. And they do feel, I think, as has been shown in much research into the experience of older members of our community as it relates to health and social care services, that it's necessary for people to have this information about them. You want someone to know who you are. You don't want the weight of carrying a secret. So this fear and anxiety of stepping out, revealing who you are when you are receiving this care in a place where you should feel safe, and you want the person to know you, but you fear that you can't trust that this person is going to deliver the most compassionate care to you, or that they may have attitudes or feelings that may result in less full care for you as a result of that. So I think it's moving on to the next slide. It kind of brings us into that feeling of taking risks, building up to building up to sharing or disclosing your gender identity or sexual orientation with someone who is coming into your home to potentially deliver care which is very intimate and may sort of be ongoing over a long period of time. We would have had people throughout the interviews sharing that they thought they were being discriminated of, not necessarily even by what someone was doing, by virtue of sort of someone being outwardly or openly homophobic or transphobic towards them, but that the way they changed, the subtle ways in which an attitude changed towards a person once they had disclosed, and then a feeling of, does this mean I feel safe? Does this mean I feel I'm receiving the optimal care which I was deserved? And needing to have that feeling of taking that up, disclosing up front to say, this is who I am, so that the person has no choice but to choose how they engage you from the very beginning. And these risks for a population who living across our society feel very hidden and very marginalized, and often feel a great fear about being out. When you can't avoid it, this is necessary care that you're receiving. We need to really take into account how we, as people who are practitioners or people who are potentially going into these homes, how do we send signals to make sure that people feel safe to be themselves and can relax and just receive the care which they need.
So, coming to terms with home care, two very important aspects: time and the recognition of needs. As with any relationship that we build with another person, it takes time. I'm talking from a place of lived experience. I'm a survivor of terminal cancer. I was 9 months in recovery after everything that you could possibly imagine going wrong. I was allowed to go home. I was given home health care. And the first person who came out to me I can't emphasize enough how vulnerable a person can feel at that point. You are in your own home. As Mel said, this is supposed to be our safe place, our refuge, our sanctuary. And I had somebody coming in who immediately showed me they were not okay with my sexuality. This person was going to be putting me into a bathtub in the next 10 minutes. And I felt afraid, I felt vulnerable. So it's as James was saying, you can upfront come out, let a person know, and give that person the option of saying, I will work with you or I won't work with you. So time in that aspect to get to know each other. The second person that came out was an absolute dream come true. We connected straight away, and we made a bond. And as James was saying, some of this stuff is very, very intimate. Coming out to someone is an intimate process. So coming to terms with home care, very, very difficult for me living independently my entire life, and then having somebody come into my home and to do things for me that I wasn't able to do for myself. So as James said again, the trust, building the trust. I think it's trust, it's understanding each other, and I guess just having that friendly atmosphere.
We tried to do a survey of home care staff, and this proved very difficult to do. We had anticipated it wouldn't be easy, but not that it would be quite as difficult as it was. It's commonplace in surveys of workers on the edge of a society to get low response rates. And there's a lot of work has been done on ways of raising the response rates. And we did what we hoped would achieve that, but we didn't succeed. So we got eventually around 60 people completed the survey out of several thousand. There aren't exact figures for the number of home care workers in the country, but there's certainly 5,000 or 6,000 people in this category. It's possible that may improve as training requirements improve, as the status of the job increases, as the stability of employment increases. But at the moment, it's a significant challenge and one that future work should not underestimate. Having said that, what we got from our responses was quite interesting, that very few people had direct knowledge that they had themselves provided home care to LGBTI people. But a significant number said they didn't know whether they had or not, which suggests, as per the discussion about coming out earlier, that by no means all clients of home care workers inform the home care workers of their sexuality. That's their choice. That's their life. What we gave them a number of questionnaires that are used to look at attitudes towards other sexualities in a society. And we found high levels of support for other approaches to sexuality, for high levels of support for gay men, high levels of support for lesbian women, and high levels of support for transgender people. We found that quite a few knew and had friends who were gay men. Rather fewer, surprisingly fewer, had friends who were gay women. And very few knew transgender people personally, but they had favorable attitudes towards them. There was a specific question as to whether they felt that care workers should have a choice about providing care or not providing care to LGBTI people, and around 1 in 3 felt they should have such a choice. So it was an interesting piece of work. It suggested a high level of favorability towards the community amongst this group, which I think reflects the wider society we live in. But there were some significant challenges in doing the work. Next slide.
So this led us then between taking the first aspect of what people of the community have had to say, and the second aspect of what those who give care to people have to say. And we took the theory with the practical examples to create what we call a MOOC, an open source educational resource. What we want to do is provide knowledge and skills. But more importantly, once you have knowledge and skills, is the confidence and the comfort to care for older people who are from the LGBTI community. Because if you're comfortable around people, regardless of who they are, people pick up on it. But we want compassion, we want awareness, and we want a humble commitment to ongoing learning. Because one of the aspects we have to think about is the history of people, where they come from, what they have went through throughout their lives, and what they bring with them into a healthcare encounter. We want to promote diversity, inclusion, and representation of LGBT-themed research and realities in education. And we want to achieve equality by respecting difference in health and social care. And our group here is LGBTI, but there are other groups who we should be respecting with equality and their difference. And we have multiple communities in Ireland where this is applicable. But our themes covered person-centered care, a brief history of the milestones of LGBT rights in Ireland, our definitions of sex, gender, gender identity, sexual orientation, use of inclusive language and terminology, sexuality and intimacy in old age. I've reached an age where people think that once you reach those milestones, that you're no longer interested in intimacy or sexual encounters. We won't go there. Emotional skills necessary to handle episodes of coming out. But that's a two-way street, because when we're older, we also need, as a member of the community, the emotional skills to trust when I come out and to trust what may come back. So both of us need those. And we have recommendations and guidelines for care. As I said, this program is on Future Learn and is called Pride at Home. The structure of each lesson, and we have 6 lessons done over 3 weeks, so it's 2 lessons a week. We introduce a topic, and each member of the team have introduced a topic close to their heart. We have learning activities, such as videos. We have texts and articles. We have definitions. Well, I am a sociologist. We tend to love definitions. So we give you the gift of our disciplines. And we also have real-life examples. And we infuse this too with the data from the study, because that is where we get our real-life examples. What do people say to us? What do lesbian women want? What does a transgender person want? What does a gay man want? What is it like to be bisexual and coming out? And what does this mean in practice? And of course, it wouldn't be a program of study without a reassessment to see what have we learned? Where are we going with what we have learned?
I suppose bringing this back from what we can hope to take away from, or what people can hope to take away from some of the course which has been created, is an understanding of the actual needs of older members of our community. And it's a diverse population, many of whom have experience, or all of whom grew up in an Ireland that was less accepting than we have come to be in recent years, and all of whom were watching with, I would imagine, a certain amount of fear and interest what is happening to LGBTI plus rights around the world. So the sense of safety that may have been developing in the lead up and across the time where the marriage equality referendum took place, that may have emboldened some people to feel as if they have that right to come out, may be sort of ebbing away now. So it's a real need for the services, for services across the health and social care services, and particularly those who are going to be dealing in an intimate way and in those safe places, that they would make sure that they have the skills to signpost their own inclusivity. Because broken down across the journey of an individual, there will be people who have had, and I know from previous research, though I don't have the sort of the figures today, that older members of our community in high proportions have experienced prejudice as a result of their identity, not just limited to within health and social care encounters, but across the entirety of their lives. And that will have created a reservation about sharing their identity with people on whom they know they are going to be relying for vital care. Also, as with this population, they're more likely to be relying on external form of cares, because by and large are likely to have, or more likely than the general population, to have a smaller support network and less of those traditional supports that individuals may rely on as they age. So that reservation from sharing comes from a place of understanding that these services that they're receiving are vital for their positive aging and continuing to be able to be to be active and to live their life in a way that they would want to. And that brings you to a point of how and when you would disclose. Are you going to do so up front and allow the individual a choice about whether they want to engage with you as a member of the community, or do you want to wait and see how the land lies? The reality is, though, as a home care professional going into any person's home, it should be your responsibility to treat that individual with care and respect, regardless of who they are or regardless of their background or their identity.
So now we're going to look at specifically the emotions around coming out, and the dynamics which happen both internally and externally. So to the person who is coming out, what is happening for them at that time and what's going on around them. So there's a disclosure and a disclose, like the person they're disclosing to. So what's happening for the staff member at that time when somebody is disclosing or not disclosing. And it's all around the dynamics that happen between two people, or maybe two carers have arrived as well at the house sometimes. For caregivers, it's about the facilitation of the disclosure and also preparation to manage your reaction to the disclosure as well. So if I can just say, I've had, at the moment, I'm nearly 50, I'm not quite 50 yet, this year I'll be 50, but I've had some home care because of a surgery I had recently, and carers coming into my home and doing procedures, medical procedures, and my wife being upstairs in the office and deciding to say, this is my wife when she comes into the room, not like this is her name, or and that actually came up within the interviews. One of the participants said she'd rather tell them up front so that they know who she is, rather than wait for an awkward moment, which I've often experienced, where people might say, well, that's okay. And you're like, well, I didn't think it wasn't okay. I was just letting you know. Or they'll say, I don't care. I don't care about that. And I will say, well, I do care about that because it's part of my personhood. So the reactions are quite important. I know we have talked about this, kind of touched on it throughout everything we've said so far, but it's about the complexity. And the complexity is highlighted by multiple reports in the literature of the phenomenon of self-closeting or recloseting. This is where someone who's been comfortable in their circle, made vulnerable by ill health or age, and they decide to start to hide their gender and sexual identity and not tell people. And it may also explain the invisibility of those who are LGBTI in healthcare, or perhaps the assumption that you've never provided care to a lesbian, gay, bisexual, trans patient or client. Coming out is a process. that LGBTI people do on a continuous basis. Multiple times a week, we consider our environment, ask ourselves, is it safe to be open about me and my life with this new person? As you can imagine, this can be extremely emotionally taxing process, and one which heterosexual, non-gender diverse people ever need to think about or do. So what we've got on the slideshow here is the definition of shame. So it's around the shame the person may be feeling, silencing oneself to be accepted. And we've shared in the education some videos throughout the education to have a mixed media approach. So Brené Brown's video about her TED Talk on shame is there as a link. We look at care workers' shame, maybe based on religious beliefs, upbringing, lack of exposure to LGBTI realities, a care worker's stance of silence around LGBTI identities, because the latter is reduced to who someone sleeps with and therefore considered irrelevant to care and actually not something you want to talk about at all. An older person's sexuality, as Mel kind of alluded to earlier. The emphasis on the broader meaning of LGBTI as including attitudes towards life, family and relationships and connections, and often involving experiences of discrimination and trauma in the past. And the consideration of this is really fundamental to delivering holistic care. This work, just to kind of finish this bit, the work is to enlighten and not to criticize healthcare providers for not knowing, because how does understanding happen without explanation and education? And just as Carl Rogers said, I'm a psychotherapist, so I'm a fan of Carl Rogers. The only person who is educated is the one who has learned how to learn and change.
And I'm going to have a look at what does this actually mean in practice. But as a home support or care worker, you're in a very privileged position to be welcomed into an individual's home, to support them and care for them, to live their life at home, which may be preventing them from having to go into residential care. And when we look at home care workers and care support workers, it's not a mechanical or a task-based orientated job that you're going in to do. You're going in and you're looking at the holistic person, the whole person. And I suppose what I really, what I'm delighted to see coming out of this piece of research, and as Mel has spoken about, the educational resources that have been put together, like from Anthony's aspect where he was speaking about that 88% of those who came and spoke in the carer survey felt they had no specific training. It's a massive gap. And sometimes if an individual feels that they haven't had the lived experience of engaging with a member of LGBTI individuals, it can be quite frightening. So I suppose having this educational resource is so invaluable. I was also struck as well that 33% said they had no experience of working with older LGBTI people. But the question is, perhaps those 33% of individuals had come across them, but the person that they were caring for did not feel they were in a position to come out to that person providing care. So as James stated, and as it says, and I think it's the first line on this slide, which is the most important, every case is different, will be different, because every individual that you come across in life is different. We're all individuals. We're all, we live our lives. And it is, as I said at the start, a privilege to be invited into an individual's home. So it's about building up that trust and that relationship with the individual person that you're caring for. Now, as a home care worker or care support worker, you don't go in just to do that task that you've been assigned. You have a conversation with that individual, and you are very aware of things. You pick up things that you might go back to your manager with and say, I'm a little bit worried about this individual because of A, B, and C. You use your intuition. And as the final point says there, often people who are LGBTI, they will have symbols, may have symbols displayed around their house. Use that to initiate the conversation. Allow the client or that service user to feel comfortable with you, to open up and to disclose, because as has been already alluded to here, those of us who are LGBTI, are always constantly feeling we're coming out to individuals. We're always careful about how. So we have to make these individuals feel comfortable in it. And also important, remember that your silence may be interpreted as indifference and shame. So allow the individual to open up as much as they're comfortable with as you're building that rapport and trust with the person that you're caring.
I suppose to add to what James was saying there is to remember that we're all born into straight communities, into straight families, those of us who are older. And one of the things we do is we have learned how to be straight, but as we get older, we decide to be ourselves, so we kind of forget. And then when somebody asks us to be straight, we don't really know how to do it anymore. So this is one of the conundrums. And I suppose in a way, if you invite somebody in to help you clean your house, most people clean it before they invite a cleaner in. But what happens within our community is quite a number of us clean away any kind of symbol that we exist in fear of how the other person may see us. So just to remember, there's other forms of cleaning that happens, which is an erasure of the self before anybody appears. Now, a lot of what we do in our assessments is vignettes. So we have an example here. You are visiting a client for the first time. You've been told his name is Patrick and that he's in his 80s. When you meet Patrick in his home, you introduce yourself, and while preparing his medication, you may make small talk and discreetly ask general questions about his life, his work, and his family. You notice Patrick wears a ring. You recently got married yourself and are happy to share that with him. But before you do, you also notice there's a rainbow flag by the window. What do you say? And I'll leave you to think about those 4 ways of what you might say. And then for yourself, choose the one you think might be correct. And when you do the program, you'll discover which one it is. So our overall recommendations for going to somebody's house to be the professional that you are as a home care provider is show openness. Be mindful of history. Be prepared to listen, but to be an active listener. To develop emotional skills. And this is possibly one of the most difficult things to do, because I myself am very good at it, is avoid assumptions and stereotypes. Do you know when you meet somebody for the first time, you come away with ways of thinking? Or even if you see somebody walking down the street. And I suppose being my age, and one of the biggest assumptions is, you know, if you're going out at night, well, if it's me, it's a coat. If it's somebody much younger than me, you go out, you take one look and you shiver and you wonder how they do it. Of course, what I am doing here is forgetting that I once was that person who caused other older people to shiver. Acknowledge and respect pronouns, and we do deal with pronouns and how to get used to saying them. I mean, don't forget, when the Queen died, the King took over. So if the royal family have no problems in changing their pronouns, and if the British people have no problem in changing the pronouns in their national anthem, I am sure then we all should have no problem in changing our pronouns. Stay committed to learning. It really does open us up to different ways of thinking. Ensure representation and use inclusive language. But one of the things, if you're not sure, ask the person. Because we will tell you, and we will help you, and we will enable you in your practice. Before thanking you for listening to us and for coming on our webinar, there are 2 things we would like to do. We have a research report and we have an online educational program.
I would like to introduce Deirdre Lang and take this opportunity to thank her sincerely for taking the time to launch our report, Pride at Home. Deirdre is the Director of Nursing and the National Lead in the Older Persons Services Office of the Nursing and Midwifery Services Director, Clinical and Integrated Programmes. Deirdre is an RGN and holds a fellowship of the Faculty of Nursing and Midwifery in the RCSI and is a Scottish Quality and Safety Fellow with an MSc in Leadership, BNS, a Diploma in Management, HDIP in Gerontological Nursing, take a breath, HDAC Level 6 Special Award in Coaching and Certificate in Ageing and Frailty. Deirdre initially trained in St. Vincent's St. Vincent's Hospital, Eden Park, as a registered nurse. During her career, she spent a number of years working in the acute service in Australia and Ireland, and she's had a variety of experience and having worked in mental health and practice development. Her experience in older person services includes her roles as clinical nurse manager, assistant director of nursing, directors of nursing, HSE and private sector. Her role as director of nursing, older person services brings together all aspects of her experience to date, together with the passion for older patient and those who provide their care. So over to Deirdre now.
It's my absolute pleasure to be invited to launch the Pride at Home report. My sincere thanks to Dr. Mel Duffy, Claire Mooney, Dr. Giovanni Ferezzo, Professor Anthony Staines, Professor Anne Matthews, James Geoghegan, Colette Gleeson, James O'Hagan and Sean Vale. The population over 65 in Ireland is estimated to have risen by over 40% between 2013 and 2023. In 2024, the Central Statistics Office estimated that there are 833,200 people over the age of 65 in Ireland, but they offered no data as to the LGBTI population. The approximate range of the LGBTI population is thought to be between 5 and 7%. And if we apply this estimation to the total estimated population of those over 65, we're talking about between 50,000 and 58,000 people in the LGBTI population and community. Older LGBTI people live with the memory of discrimination throughout their lives, particularly any form of discrimination or prejudices that they received while in healthcare. It's well documented how past experiences inform current situations, making many older LGBTI people very wary. Many older LGBTI live with the memory of being immoral, criminal, and being in need of psychiatric intervention. Remember, homosexuality was only decriminalised in Ireland in 1993. Paired with the risk of being arrested because you were not heterosexual, LGBTI people were seen in healthcare as needing fixing, and this rendered them in need of psychiatric care. The model that older LGBTI people grew up with was therefore threefold: a sin, immoral; a crime, criminalisation; and an illness or disease needing psychiatric intervention. Medical treatments became the new form of punishment and social control, so that the medical profession became influential in defining identity and sexuality, which in turn permeated into cultural norms. This is the history of many of our older LGBTI family members and many of your clients. Coming out is a precarious affair, whereby LGBTI people usually choose when, where, and to whom they can relate their sexuality. It involves making decisions on whether to disclose or not disclose based on whether it's safe to do so, resulting in the process of being fraught with the unexpected, from social acceptability to rejection. Coming out is not a singular activity, but it requires indicating one's sexuality time and time again. Now consider your home. Someone arrives at your door and you're at your most vulnerable as a stranger enters to carry out the most intimate of care. Remember, past experiences form your thoughts on how this interaction will go. How do you feel? I would suggest you feel fear, anxiety, never mind the normal anxiety of a stranger touching you and you being seen at your most vulnerable. The fear of rejection as a human being and of being treated differently. What does that feel like? And so let's talk of pride at home. 88% of healthcare professionals who were surveyed reported no education or training in dealing with the community. 33%, in fact, were not aware if they had experienced interaction with the LGBTI community. So the study aims were threefold. One, to identify the home care experiences of the community and their support circle, and they did that through interview. Two, to uncover the knowledge and attitudes of professional caregivers providing home care services to the community dwelling older LGBT people and their support circle, and that was done through a survey. And finally, to co-develop an educational toolkit that would lead to improved practice and quality of home care services received by community dwelling older LGBTI people. This is the first education program of its kind nationally and in fact internationally. There's been nothing like this before. So the hope is that this can be an inspiration for the creation of other resources in other contexts in the shared purpose of improving the inclusiveness of care services destined for sexual minority groups, so that they are treated as everyone else and at the same time recognized as individuals with a distinctive set of needs that includes awareness and consideration of their histories of invisibility and inequality. Pride at Home was developed to enable those working with sexual minorities to care without discrimination or preconceived ideas about LGBTI people. Those who undertake the programme will learn to practice from a human rights, open-minded framework, thus embracing the person they meet in their own home. And their logo speaks to this with the caring hands embracing the rainbow home. So a few tips. Always do math history and fit the age of your client within a larger framework. Remember that anyone who is age 50 or older has spent some part of their adult life fearing that their sexual orientation could get them into trouble, outlawed, pathologized by medical professionals, and also living within a spiritual alienation, and in some cases, in fear of abandonment or having experienced abandonment by family. Show kindness and provide reassurance through your words and behavior that you are aware of this and that you empathize with them. Not for being a member of the LGBT community, but for having to survive the minority stress within a society which was historically unaccepting and at times cruel towards them. Finally, please, show openness, be mindful of history, be prepared to listen, develop your emotional skills, avoid assumptions and stereotypes, use inclusive language, acknowledge and respect pronouns, and perhaps ensure representation by having a rainbow lanyard or a badge visible for LGBTI people so they can see that, and that will allow them to absorb the support of your organisation and of your individual key support people. Thank you.
Joanne is a secondary school teacher. She's from Ireland. She was a critique breastfeeding counsellor for a number of years.
That's you too.
As you've noticed, they like to take my age away from me at times in the school. It's my honour and my privilege to introduce you to Alva Smith, who's a long-time activist on feminism, LGBTIQ+, and other social issues, and was the founding head of the Women's Studies at UCD, where she lectured for many years. She played a leading role in the marriage equality referendum campaign in 2015 and was coordinator of the national referendum campaign on abortion in 2018. She is chair of the Women's Aid and also of Ballyfermot Star Addiction Services and is on the board of Age Action and of the Women's Global Health Network. She is patron of the Women's Collective Ireland. In 2019, she was included in Times Magazine list of the 100 most influential people. She was awarded an honorary doctorate in laws by the University of Galway and is a free woman of the city of Dublin. Dr. Smith will now give her talk.
Thank you for inviting me to be here with you today. And I can tell you, I am absolutely delighted. I'm just going to alter my screen here a little bit there. That's better. I'm delighted because, you know, it's not every day that you read a research report where you find yourself saying, oh, it's the very report I've been waiting for. This is what I've been waiting for such a long time. It is very welcome. It is very, very timely because, of course, as you have been saying, and as Deirdre Lang was reminding us, we have, of course, an aging population in this country, as we do throughout Europe and the so-called really globally, I suppose. And in that aging population, of course, the LGBTIQ population is also aging. It sometimes seems to me that we're almost aging more quickly, but that may be a very subjective view. But it is still a very youth-focused community overall, if I can kind of generalize. And there's very little talk, almost no talk, and very little visibility, really, of older LGBTIQs, socially or, and very importantly, in terms of health and care, as well as so many other issues to do with finance, to do with housing, to do with all the kinds of needs that you have as a human being. Now, of course, you know, attitudes towards LGBTQ people have changed very radically during my lifetime. But as you've all been commenting, those of us who are over 50, and to be perfectly honest, I really love this, those of us over 50, I mean, I'm heading very close to 80 right now. And I'm telling you that there is there a lifetime, certainly for people of my older generation, if you follow my mathematics there, there is a very difficult set of histories, I mean, complicated histories, of course, and to do with other factors apart from sexuality and gender identity, but which of course always have to do with social class, with ethnicity, with ability, stroke disability, and so on and so forth. But there is typically a very, very, very marked experience of stigma, of prejudice, of discrimination, of cruelty, and sadly, there can be too of violence, as well as very, very common experiences of isolation, ostracization in our workplace, from our families, in broader, wider communities generally, as well as really that silence that always hovered over us and which we ourselves had to be, in a sense, complicit with in order to survive our lives. And then you also have another complexity to deal with, which is the one which is not exactly masked, it's more indicated by the alphabet, LGBTIQ, where this is not an equal level playing field, as I think we all know by a long shot, where if there is now, and there is, I think, this much wider acceptance of being lesbian or of being gay and indeed bisexual, that is absolutely not the case when it comes to being trans, and it is totally not the case for people who are intersex. And that's indicated, in fact, by the responses to the request for those to step forward for interview, for example. So, you know, it is, I think, really a very complicated area. I mean, interestingly, when it comes to health and care needs, in many ways, of course, those of us who are LGBTIQ and so on, we have the same needs, similar needs, the same kinds of things that come about through the aging process. And I could go on about these forever from a personal point of view, but don't worry, I'm not actually going to do that right now. But it's not the same because, and the ways in which we both access or don't access health and healthcare and care are really quite different because of our very different backgrounds and experiences. And I think perhaps the strongest marker that I think of when, as you know, just as an older lesbian approaching healthcare, is that there is that sense anxiety and fear of judgment, fear of discrimination, fear of a different quality of care, a different kind of attitude. It's those sort of moral and social issues that you can feel coming at you. So that when, and I think, but although I think I did mean to say there a minute ago that, I mean, like heterosexual people, LGBTIQs are also looking as we grow older to have care in our own homes. I love that phrase, in place. I always want to say, what place, what place? And when I talk about home, and I think actually it was Mel who mentioned it at the very beginning, not all of us have homes. I'm very privileged, I'm very fortunate, I do. But there are many people I know in my community and outside it who even in older age do not have homes. So I'm thinking, I think I'm talking about care even kind of more broadly. But just focusing on home for a moment, as has been said, if you have one in which care can be provided for you, that's already your good fortune in a way. But it's also a very precious and a very private space for those of us who have had acute experiences, very distressing experiences of being ostracized, of being made to feel other and different and unacceptable, of being stigmatized, so that your home is that real refuge, if you have it, however big, however small, however modest, whatever it is your sanctuary. It is that place where you can let go of the fear and the anxiety and where you can really be yourself. So I think that when you are admitting the stranger, that is the care provider, to that space, that issues of trust, as you've all mentioned, are absolutely central. Can you trust that person to see and accept and understand you as you are and in who you are? And that is so important. And that's really the key question at the heart, I think, of all of this. What might the reaction be? How might they respond if you do actually come out to them? And again, I was so pleased to see it noted in the research. We are so trained, we are so well trained to know by the flick of an eyelash what you actually think or what people actually think about. You don't have to say a word. It's just there in your body language. It's there in the way you laugh or smile or don't smile, in the tone of your voice, in the flick of your finger. I know exactly what you think of me in relation to my sexuality. And that can't be masked, by the way. So, but issues of coming out are, of course, absolutely vital and crucial in all of this. There are the questions about if, there's the question about how, there's the question about when, and there's always the question about how much. How much do you come out? How much can you take how much can you sort of gauge the other person's response to taking all of you as lesbian or gay or trans or intersex, all of what's entailed in that. And that very often hovers around sex, but also are very different kinds of ways of making relationships, of forming families, and so on and so forth. And the other very important question when we're talking about care being provided at home is how often? Because my own personal experience of having had care at home is that the rotas change all the time, and you're going to have to come out one day to one person, and the next caregiver, the next person who comes to your home may very well be, and usually is, somebody quite different. So you've got to do it all over again. So that notion of coming out, you never do just come out once, coming outs for every day. And that also holds true within the care and place situation. And we absolutely need to bear that in mind. And those anxieties, that anxiety around your sexuality, and even more so, I imagine, around your gender identity, is layered and imbricated with those anxieties that you have as someone who is aging, someone who is growing older, someone who is seen as old, your sense of having someone coming into your home to look after you is about being dependent. So you are seen as someone who cannot really look after themselves. And that is a hugely vulnerable situation to be in. And it's one of the hardest things of all about growing older. And I can say that as having had some experience, fortunately not too terrible, but having some experience of that, of losing my mobility, for example. And well, you know, we needn't go into the details, but it makes it all the more important that care providers should know how to navigate all those complicated dynamics. And that's a lot to ask of people, care providers who are extremely busy and very, very pressurized people. So I think that having a training program, which, you know, for people who are providing care, probably lessens their concern and worry and anxiety of, you know, how to deal with suddenly being confronted by an older person who says, well, you know, I'm lesbian, I'm a dyke. And there's a kind of a silence, and you think, oh my God, how are they going to deal? She thinks to herself, how am I going to deal with this? I'm exaggerating there, but what I'm saying is that if, as the person who is providing care, you feel confident in yourself, that you know how to provide person-centered care for people who are members of sexual minority groups, that makes your life as a carer so much easier too. And I mean, I do know that from personal experience. If I had, I suppose if I had €1 or whatever for every time I've seen people's eyebrows go up when I say, well, you know, I'm lesbian, and the eyebrows hit somewhere up there. And they say things like that, oh, right. And it's a bit like saying, oh, well, if I say I'm 78, they say, well, you don't look it. And it's a little bit like the same thing. Oh, but you don't look it. Well, what does a lesbian look like? What does a 78-year-old look like exactly? And I so identify with whoever it was who said that one of the things that's actually very difficult also to take is if I do say that, if I do come out, and the person then says, oh, well, sure, I don't care what you are. No, I want them to care about who I am. I want them to understand that my life is maybe different from hers or from his if they're straight. I want them to acknowledge that difference and to work with it, to let that be part of the relationship dynamic, that dynamic that we build together. As one of the people interviewed says, you know, you have to communicate in these kinds of relationships. And they are about friendship, ultimately, if you're getting a fairly regular care provider. They are about building those relationships. So they need to be really quite mutual. I think this is a wonderful, wonderful piece of research, very careful, very thoughtful, all the way through. Brilliant literature review, let me say. Congratulations all round. And the toolkit is just fabulous. I did try, Mel, to get in. I couldn't actually get in to see the course in a lot of detail, but I have read the outline, and I think you've got the balance absolutely right. And I really want to thank all of you for doing a fantastic piece of work. I think it lays the groundwork for the other research that needs to follow. I also think that this piece of work itself and the toolkit has much wider application throughout our healthcare services more generally. It's not just about LGBTIQs, but thinking of many communities which would, I'm sure, be incredibly appreciative of having this kind of groundwork given to, and the possibility for people doing caring in those areas to have access to as well. So thank you so much for all of it, and thank you for letting me be with you today. It's been a real privilege.
We have one in our question box, and it's from John Gilmore, and he says, "Thank you to the whole team." And forget about the other part. Thank you very much, John. Well done. I'd like to hear the panelists' thoughts on the development of a database of affirming home care workers and an adoption of a policy by the HSE to only assign such workers to LGBTQI+ folk if they are agreeable as part of the care plan process. Yeah, sure. We've one medic on the team, so we're going to hand it over to Anthony to ruminate on that one.
Okay. I think the most basic principle is that if you're a healthcare professional, your obligation is to provide healthcare to anyone, whether you like them or not, whether you approve of them or not, is irrelevant. You're going to provide better care if you understand other people, but nothing absolves you from the responsibility to provide care. That's why doctors and nurses care for enemy competence and work, for example. Maintaining a database of the social attitudes of healthcare workers or community health workers, or whichever group you want to focus on, would be both practically very difficult and I think would be a bad principle, because people's attitudes change. Today, you might know nothing about trans people.
Yes.
Yeah. Tomorrow, you might meet some trans people and get to know them, get to understand a bit about where they're at and where they're coming from, and how best you can effectively relate to that person, not to some hypothetical imagined trans person, but to the person sitting in front of you, the person sitting beside you. And that's going to change over time. How do you maintain such a thing? Is it a good idea? I think that people choose to provide care because they like caring for other people. And it is people they want to care for. I've not encountered people who want to care for only redheads, only people with one ear lower than the other, only people who are very clumsy and awkward, because that doesn't happen. So in the same way, I think you have a responsibility to provide the care. You may need to decide which group you're going to provide care to. We have specializations. Some people provide, I trained as a doctor looking after newborn babies, which is what I really like doing. One of my colleagues trained as a geriatrician. You spent a long number of years in gerontology, other end of the business spectrum. But those are our personal choices. But I'd still, if you fell in the street at my feet, I wouldn't ask, well, are you under 3 months? I'd look after you. So no, I understand where you're coming from. I really do, but I don't think it's a good idea.
I would also worry that some organisations may opt out and then therefore refuse to provide care for LGBTI people. Yeah. We're not trained or something, and therefore opt out, and thus reducing the groups that can provide care, which in these days is so difficult to recruit. James, you probably know about this from working in the community, that it is difficult to recruit people, and it would narrow it down so much that it would mean that we would actually be at a disadvantage to getting any care of any kind, I think.
One of the most consistent messages that we would get through people who are contacting us in LGBT Ireland as it relates to healthcare is looking for a list or a database of GPs or counsellors who we know to be sort of LGBT inclusive, and I think that really speaks to the fear and anxiety that our community have about accessing these services. And you know, when we have conversations internally about it, there is a real sense of not wanting to silo ourselves off, but also perhaps that there is a need for a private home care company to establish itself and really broadcast itself as LGBT inclusive, so people can see that, and if they really don't trust the care options that are available to them through the HSE, that they know that there is somewhere else. I do also think that there's, you know, we need to invest much more in how we respect and perceive home carers, and make sure that home carers are seen as, you know, not just sort of a throwaway profession, that it's something that really is that is really valued as well.
Okay, Colette, welcome. Colette
Thank
is
you.
also one of our team, and I'm going to give you a plug, Colette. She comes from Comfort Ireland, Comfort Keepers rather, and so she is going to be the person who's going to push this and roll it out in the home care sector. No pressure.
Absolutely, yeah, not at all. I think the question, I totally agree with Anthony. I think we've moved forward. I do think as providers we have a responsibility to make sure that people are adequately trained, informed, are given space to learn, to be educated, to communicate better. And I suppose our commitment and part of this, I suppose part of the research and part of the training is to ensure that all of our staff have it as a baseline. And I think what I want to work with, and with Comfort Keepers, but also with HSE, with QQI, is how do we get this to be a fundamental module in community care, because it is about person-centered care. So we talk about that a lot. And I think that the big directive we could get is that it becomes a core fundamental part of anybody who's, I suppose, coming into health and social care in any way, shape or form, from a level 4 to a level 10. It shouldn't be left out at any stage, and even earlier, trying to get it to a school level, because it is all about an approach to people, and exactly that. Care is care. It's not about differentiating, but I don't always think people have that fundamental understanding of themselves and how they impact. So they believe they're compassionate, they believe they care, they believe they understand people, but they don't realize their own language, their own behaviors, and where things can happen. And I think that's our drive now, will be to make sure that our teams, and I think Comfort Keepers then as a responsibility. I think the use of the PIN is really going to help as an outward evidence of having done that training. So as our team go into the community and they have these PINs, as they meet people, it will demonstrate to that person that they have maybe the right education and training. I think secondary to it is we need to educate our clients and our customers and the public that this training exists, so they can ask providers, have you got this? Is this part of your core training? And that's what we will be advocating for. It's a combination, rather than, I suppose, further segregation of people who are happy to work with so many people or not. And I agree with Claire, we have a capacity challenge, we have a workforce challenge in health and social care. There are so many barriers to getting involved. At times, from whether education, through vetting, through all so many pieces. We have to make it a little bit easier and more centric for people to get access to better information, and that will, I suppose, make life easier. Our job in Comfort Keepers is to preserve and drive quality of life. How do you do that if you don't know what matters to someone, and what is quality to someone? Quality of conversation, quality of relationship, quality of the place that they stay in. And as a home provider, even personally, it's something we're deeply passionate about. We talk about care, we can talk about illness and infirmary, but it's the opportunity of amazing connection, of elevating, of keeping someone safe in a space where they are truly and freely themselves. And that is our responsibility and our commitment to this programme.
Well, just very, very brief. I was just very taken with what Colette was saying there. It's brilliant to hear that. just thinking about what Anthony was saying, you know, I sometimes have felt when someone was coming to as a recipient of care, let's put it that way, that, you know, I've been teaching that person how to behave with me, and they have learned and embraced it. And therefore, the notion of a database seems, it's kind of anathema to me a little bit, because there is that sense that people very much learn on the job. Just as, I mean, I sometimes think that in our LGBTIQ community, we're actually making this up as we go along, learning how to be older LGBTIQs, because we don't have role models there. So that there is a kind of mutual learning that happens, which is actually very interesting and very heartwarming actually.
Yeah, to be honest, I think Colette and Alva have really covered me off. I think my hand went up, I should have taken it down, but I'll make two quick comments in relation to John's question. In fairness, it's, you know, it's a very fair question to ask. You know, if you're an individual person living in your own home who requires care, you're in a vulnerable position, and you're inviting a stranger to come in. And as Alva has alluded to earlier, she had some care in. You wouldn't know exactly who was going to be in with you day on day because of the challenges about capacity and staffing. You're not guaranteed to have the same individual in every day. I suppose 2 points. One, it's about building and trusting a relationship. I think it was very stark that 88% of the carers who returned the survey said they had no formal training. You know, I think this is a foundation stone for anyone who's going in to help get the words or get the, you know, get some understanding or basic understanding. So if they do go into that home of that vulnerable person to provide care, that they you know, they don't raise their eyebrow, that they engage, they probe, they go as far as that individual is willing to engage with them or be open with them and build that trusting relationship. I think as an organization and as the HSE, we have a lot to do in regards to this. I would say in relation to trying to work with the private providers who provide home care to try and get make it an attractive job to go into, to see it as worthwhile, to, you know, to see that, you know, you're very privileged, you're helping an individual. Fundamentally, what matters to them is to remain at home for as long as possible, and you're supporting them in this, and you want that individual to feel comfortable in all aspects and holistic parts of their life. So in relation to it, I would like, you know, James did allude that they do get phone calls asking, you know, for GP friendly or GPs who would be LGBTQI friendly. I would go, you know, if I'm looking for home supports, I would go, you know, if there are private providers, which private providers are LGBTI friendly? Who has provided the education and the training to their staff to ensure that an individual feels comfortable in their home?
Last but not least, I get to end the session. First and foremost, I'd like to thank everybody who came online to be part of this presentation and to hear what we have been doing in the last 2 years. Secondly, I would like to thank each member of the research team. Without you, this would never, ever have been what it is. And I am extremely grateful for all of you who came on board and who were part of it, right from the moment we started and right to the end. Any flaws, of course, will always be mine, but I will share them around later. Thank you all very much.
And we want to thank you, Matt.
Yes, absolutely.
Superb leadership.
Thank you very much.
Thank you very much.